Hello friends, I am Dr Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. When there is a PC defect and we have to place the IOL in the sulcus, most commonly we use non-foldable larger optic IOL, which is the least expensive option for us. Now this is a case where the patient had posterior polar cataract. I have operated patient's other eye, and this eye was operated elsewhere, and the surgeon noted PC rupture. So after anti-vitrectomy, a PMMA IOL of 6 mm optic and 12.5 mm overall diameter was placed in the sulcus, and this patient was suffering from some refractive error. You can see there is a cylinder as well as spherical error. Patient was a driver by occupation, so he was having trouble with the glares, as you can see the optic edge is coming in the pupillary area. Now what are the causes of decentration of this IOL? One haptic may be in the bag and other may be in the sulcus, causing the tilt and decentration. One of the haptic may be kinked or damaged, and the sulcus diameter itself might be bigger than the IOL size. This is a 12.5 mm IOL and the sulcus might be bigger, so that may cause decentration. Now we commonly use this IOL in India for sulcus placement, as it is the least expensive of all, and we find fairly good results with this IOL, but as you can see, in some cases it may not center very well in the sulcus and may need to be exchanged. Now here, to take care of the against the rule astigmatism, which is because of the superior tunnel which was done by the surgeon to remove the nucleus probably once the rent was noted, so that has caused against the rule astigmatism, and that's why I am going to take a temporal scleral incision. Now side port is made and the anterior chamber is filled with OVD 2% HPMC. Now entry is made from this temporal incision. You can see that the scleral tunnel is very close to the limbus, just 0.5 to 1 mm. So it will induce some amount of with the rule astigmatism as it flattens the horizontal meridian. I enlarge that scleral incision to 6 mm, and now I am going to rotate this IOL into the anterior chamber. The eye is already vitrectomized. Anti-vitrectomy has been done properly, so you can see there is no vitreous there. I was just checking after rotation of the IOL whether the IOL centers, and it was centering alright, but of course I have to exchange this because of the refractive surprise as well. But I think redialing the IOL is also another option. Of course, here I don't want to take another chance. The patient was quite worried about the glares, and so now this is the method to remove the IOL from the anterior chamber. One Sinskey hook underneath the IOL optic and another Sinskey hook was pulling the IOL out. This way you avoid it getting stuck in the incision or avoid getting the iris incarceration while removing the IOL. Now I am going to use a 3-piece foldable IOL. Even the 3-piece PMMA IOL will do if it is available. So these PMMA haptics are much better for sulcus placement because of their springy action. They fit into the sulcus well. Now I can directly insert it in the anterior chamber as well, because I already made 6 mm large scleral tunnel, but here I decided to inject it through the B cartridge. Sometimes it's easier to do it this way, and the important thing is to let this IOL open in the anterior chamber and do not try to push it into the sulcus in the first go, because sometimes the haptic may just pass into the bag and may go into the vitreous if you are not careful. So first let it open in the anterior chamber and then you carefully rotate the haptics into the sulcus. Just watch how the haptic goes into the sulcus, touching the pupillary margin. That's very important. There should not be any gap between the pupillary margin and the haptic when you are rotating it into the sulcus. Otherwise, again, it might just go into the bag and may drop into the vitreous. So now both the haptics are in the sulcus. The anterior CCC margin is not small enough to do the optic capture, so I have to leave it in the sulcus itself without optic capture. Now I have done the biometry using optical biometer IOL 700. For sulcus placement, I generally reduce the IOL power by 5%. So if it was a 20 diopter emmetropic IOL power, I will put 90 diopters in the sulcus. Wound is sutured with not so tight sutures, just to avoid any gap, as this is a partially vitrectomized eye, so we don't want any AC collapse in the post-operative period. These sutures are buried into the sclera and wound is closed. You can see that the IOL is now nicely centered, and patient did quite well. Patient got 6/6 unaided vision. The biometry was perfect. The scleral incision reduced the astigmatism by 1.5 diopter and giving a perfect post-operative result. So let me know your comments whether you use this IOL very often into the sulcus and how are the results. Thank you.